As many of you are already aware, Dr. Gilliam is a doctorally prepared nurse practitioner and certified HIV specialist who serves as a clinical specialist for the AEPC NCHCMC. Dr. Gilliam?
Hello, everyone. I'm excited to be presenting our first mini webinar for HIV providers and care team members. These 30-minute webinars are planned for every other week, and we will ask for your feedback regarding the best day of the week and the best time of the day for these live sessions. Each webinar will be archived and available for 2 weeks following the original presentation. Each slide set, along with any supporting materials, will be contained in the Building the Foundations tab of the Virtual Learning Lab. If you have any difficulty locating these webinar materials, please contact Jarrett Casanidi, your Virtual Learning Lab expert. It's important, if you're new to providing HIV care, that you have a good foundation in several basic areas that will support the decisions you will make while treating your patients. The first of these basics includes labs and other diagnostic and screening tools that will give you a set of baseline information for each patient. I very much want these sessions to be interactive for you and for me. I'll try to pause at the end of each slide to give you a chance to ask a question or make a comment. Remember to either click the chat button or the raise hand button, and Victor, our session moderator, will read your question and comment aloud. After your question has been acknowledged, please remember to click the raise hand button again to lower your hand so that we will know if you raise it again later in the program. Today, I'll try to provide an overview of the labs that are recommended for a patient who is new to HIV care. Remember, you may be seeing patients that are newly diagnosed and fairly recently infected, those that are newly diagnosed who've been infected for many, many years, and those who've been diagnosed in the past but who have not been receiving regular care. The information I present today applies to any of these types of patients when they first appear in your clinic, unless you have records, recent records to suggest otherwise. Anything different or unique to a specific patient will come during the second phase of the workup. I'll also discuss those labs that are specific to HIV patients. I'll spend more time on these HIV-specific labs since they may be somewhat new for you. Certain lab values can be helpful in the selection of a specific antiretroviral medication and also helpful to identify those that you should avoid. We'll talk about how they're used to monitor the patient's immune system and need for both initiation and discontinuation of prophylactic medications for specific opportunistic infections. The guidelines for the prophylaxis of opportunistic infections will actually be the topic of our next webinar on August 5th, along with some information on immunizations for the HIV patients. I will explain how certain labs will guide...
Question.
What?
Keep going, Pat. Keep going.
I will explain how certain labs will guide the decision about when to begin antiretroviral therapy, as well as to monitor the efficacy of treatment. We'll have just a short discussion on monitoring and frequency because there's a PDF copy of this table from the most recent January 2011 DHHS guidelines for the use of antiretroviral agents that will provide you a quick reference for the suggested... Who's talking? Suggested frequency of the labs and other screenings that we talk about today. I'll just remind you that this PDF, these slides, and any other pertinent references will be housed in the Building the Foundation section of the Virtual Learning Lab. I also wanted to mention today that the information presented is covered in the DHHS HRSA-HAB Guide to HIV Clinical Care, the large text that I gave you during the launch meeting on pages 73 to 94. Please take just a few minutes to read these pages and begin to acquaint yourselves again with this resource. I hope you'll find it to be succinct, well organized, and easy to use, not only as a text, but also as a great desk reference. The baseline laboratory tests for patients newly admitted to your clinic will include these particular tests. You'll notice that the first three are highlighted in green because those are really the only three that are different than the basic tests that you would run on pretty much any patient admitted to your clinic. The CD4 Lymphocyte Cell Count, or T4 Cell Count, the plasma HIV RNA, which is the same as an HIV viral load, and then an HIV drug resistance test that is called a genotype. We'll go over each of those in detail shortly. In terms of the basic chemistry, if a glucose is high, it's important to confirm prediabetes or diabetes before you select your ARV, and the same is true of a fasting lipid panel. There is some information to suggest that certain drugs may worsen blood glucose, lipids, and especially triglycerides, and that information you'll need to have before making those types of decisions. When looking at renal function, it's recommended to track the patient's GFR using the Cockcroft-Gault formula. A low GFR will not only guide your ARV selection decisions, but will also be used to look for renal effects of the medication and can be used for renal dosages. AST and ALT give you an idea certainly about liver function. Abnormal liver enzyme transaminase levels may indicate the need for a further workup and may also influence your choice of antiretroviral agents. In the next slide or so, I'll talk a little bit more about hepatitis in the presence of a profound immunodeficiency and suggest what you might want to do in the presence of a significantly elevated AST or ALT. For abnormal hemoglobin and platelets, in the absence of a specific etiology, may simply be the result of a very suppressed immune system. You will also most likely find that the patient will be a candidate for immediate ART, and the treatment of the virus will likely improve both the hemoglobin and platelets over time. This is the case, too, with many other problems that you'll see on admitting these patients with drastic immunosuppression. If you add low albumin into the mix with low platelets, this may also suggest chronic hepatitis. Oh, I should say something about the urinalysis, sorry. The urinalysis should be run annually on these patients. Currently, the number of CD4 cells is the key indicator used to guide the decision about when to start antiretroviral therapy. Some experts recommend obtaining 2 baseline measurements of the CD4 count before decisions are made. I personally use this as my baseline too. I always get 2 CD4 counts. I'm just going to mention here that the CD4 count is routinely ordered every 3 or 4 months before the patient begins antiretroviral therapy, as well as when you initially begin that therapy. Once the patient is on therapy for a while, the viral load is undetectable and everything else about the patient is stable, that frequency of monitoring will be reduced to every 6 months or so. Don't worry about remembering all these frequencies. You can look at the table that I showed a second ago, and there's a PDF copy for you to download to get any more of this information at a glance. The CD4 cell count is also one of the strongest predictors of subsequent disease progression and survival. The CD4 count is used to predict the risk of opportunistic infections and used to guide initiation and discontinuation of prophylactic medications. The CD4 count is not actually used to monitor effects of treatment, but it can be used as a surrogate marker to show improvement in the patient's immune function as well as improvement in their overall health. The CD4...
Question from Brad Ward. Brad, would you like to ask your question?
Yes, Dr. Gilliam, at what CD4 count do you recommend beginning ARV therapy?
I'd love to cover that today, but that would probably take another 15 minutes of discussion. The current recommendations describe starting medications and starting the discussion of medications at a CD4 count less than 500. There will be a discussion of determining patient readiness to start medications. I remember when I first started doing HIV care, I'll never forget that my mentor said, it's never an urgency to start medications unless somebody has the diagnosis of AIDS and they're severely immunocompromised. It's really much more important to decide if the patient is ready and willing to accept the responsibilities of taking medications on a consistent basis. And so the time of a CD4 count between 350 and 500 will give you months to have those conversations with patients. But we'll cover that in probably webinar number 3 or 4. Is that good?
Thank you very much.
You're welcome. CD4 cells are a subset of lymphocytes. They can also be referred to as CD4 lymphocytes, T4 cells, T4 helper cells, T helper cells. Patients often walk in and the first thing they ask you is, what's my T4 count? Incidentally, a little sidebar about patient education. When teaching patients about lab values, we always want them to understand that a higher CD4 cell count represents a healthier immune system and a healthier patient. When educating patients on these labs, it's common to explain that T4 helper cells are like your body's soldiers to fight disease, and you always want more soldiers to guarantee success to win the battle. Your absolute CD4 count is actually a calculated value by multiplying the total number of lymphocytes by the percent of CD4 cells. The normal range varies per laboratory, per area of the country, per population for that particular lab, but the normal range is somewhere around 500 to 2,500 cells per cubic millimeter. Another way to look at and report CD4 is the percentage of total lymphocytes. This percentage is more stable over time and not influenced as much by internal and environmental factors. It's important that the providers and patients be aware of the substantial variation in CD4 cell counts, especially during acute illness. It would really not be unreasonable to reschedule follow-up labs if the patient is sick, because not only would the CD4 cell count likely be lower, but you might also even see a small increase in their HIV viral load. The normal range for the percent of total lymphocytes, which the normal range for the percentage of CD4 count as a function of total lymphocytes, somebody make a note that I need to change that to make it clearer, is between 30 and 60%. I wanted to mention here that there is a certain definitive marking place when a patient moves from HIV disease into the category and diagnosis of AIDS. A diagnosis of AIDS is defined as an absolute CD4 cell count of less than 200 or a percentage CD4 count less than 14%. Remember that AIDS is a label that characterizes a specific end stage in the progression of HIV disease. A person with AIDS is a person that's had HIV disease for many years that was either not treated at all or treated sporadically from a drug adherence perspective or an in and out of care perspective. If a patient's CD4 is ever less than 200 or less than 14, it's important to record this value and try to maintain a copy of this record, or these days a scanned electronic document, because a diagnosis of AIDS carries with it access to an entirely different level of services for that patient. The plasma HIV RNA, or what we often hear called the HIV viral load, is primarily used to monitor the effects of antiretrovirals. Historically, it was also used to help guide the initiation of therapy, but it's not really included that way in the guidelines any longer. There still exists in the minds of people that do HIV care an arbitrary classification of patients with either high or low viral loads, and we usually now think of a high viral load as one that's less than 100,000. Many drug trials actually group the patients into two subgroups and test drugs not only for the level of drugs but the frequency and such, with viral loads less than 100,000 and viral loads greater than 100,000. the assumption being made that a viral load of greater than 100,000 copies per milliliter represents a more aggressive virus. A viral load greater than 100,000 often factors into the urgency of initiating therapy. We'll talk more about this and go through some specific cases when we get to the webinar of when to start antiretroviral therapy. The plasma HIV RNA, the goal of therapy is to prevent HIV viral replication that will eventually result in a lower HIV viral load over time. The goal is a viral load that is undetectable, and undetectable is the number of copies less than the lower end of sensitivity of the assay that you're using. These assay sensitivities do vary per manufacturer, and they do get better over time. When we first started measuring viral loads, the lower level of sensitivity and detection of the assays was 500. Then they decreased and decreased and decreased, and just earlier this year, now the most ultrasensitive commercial assay has a lower level of detection at 20 copies per ml. HIV resistance testing is used to identify viral strains that have mutated from the original wild-type virus that all of the antiretrovirals were designed to target. They are most useful in geographic areas where the prevalence of mutated virus is greater than 5%. A little over a year ago in Florida, we started to look at the prevalence of multi-drug resistant virus in the state and in specific pockets around the state, and everyone that was newly diagnosed with HIV had a sample drawn and sent to the state lab to run a genotype. And it's actually been found that the prevalence of resistant virus in the state of Florida is approaching 20%. So that means that the simple once-a-day pill or 3 pills a day that are in your preferred first-line regimens may not work, probably won't work for those particular patients that are infected with a mutated virus. The two types of resistance tests are called genotype and phenotype. A genotype will identify specific mutations along the reverse transcriptase and protease segments of the HIV genome. Drugs in the basic 3 classes of antiretrovirals were designed to bind to specific areas in these 2 segments. When mutations occur, they result in spatial configuration changes that affect drug binding properties, and the drugs become less effective. Not to try to oversimplify this testing, because we will spend a session, another mini webinar on resistance testing later. There are a number of mechanisms available for all of us to assist in interpretation of these lab tests. We'll make sure that you're in touch with the folks in your local area that can help identify the least expensive way to get these tests, which sometimes are even available through your state lab. And we'll also identify some local resources to help you in interpretation of the genotypes should you need it. A phenotype directly measures the effectiveness of a specific virus in the presence of antiretrovirals. It's a test that's used down the road, so to speak, if a patient develops resistance to many of the antiretrovirals and there's a need to look at a combination of drugs so that we can put together a potent regimen from a group of partially active agents. The current recommendations for when to run a genotype is that a genotype will be run for all patients entering care regardless of whether antiretroviral therapy will be initiated now or will be deferred to a later time. If treatment is deferred, another genotype is suggested prior to antiretroviral therapy initiation. Genotype testing is recommended for all HIV positive pregnant women, and antiretrovirals are also recommended for all HIV positive pregnant women at the end of their first trimester. There is another table that we have included as a PDF in the basic Building the Foundation section that gives a little bit more information about the resistance assays, and it's just there for your something. Okay, I'll fix that. Additional lab tests that will need to be ordered include hepatitis serology for hepatitis A, B, and C, a pregnancy test for all females, toxoplasma antibody IgG, the CMV antibody, and a glucose 6-phosphate dehydrogenase or G6PD. Testing for, I'm going to talk a little bit more about hepatitis serology in the next slide or so. Testing for toxoplasma antibody will detect a latent infection with Toxoplasma gondii. An emerging toxoplasmosis infection, a new acute infection, almost exclusively occurs because of reactivation of latent tissue cysts. If the patient is positive, this will be important if their CD4 count is less than 100 cells per millimeter cubed, because they will need prophylaxis. That's our next webinar, and we have some handy-dandy charts for all of these prophylactic numbers that you'll need to remember. If the patient is toxo-antibody negative, you'll want to provide counseling to prevent exposure to the organism, primarily in undercooked meats and in cat feces. The CMV antibody test has been a long-standing baseline test. There's actually discussion lately surrounding the need to continue this test at baseline. Number one, because greater than 99% of U.S. citizens are CMV positive, and number two, there's little CMV disease any longer in this country when patients have a healthy CD4 count and are taking potent antiretrovirals. If blood products are needed, there is still a need to test, because if the patient is CMV antibody negative, we intend to provide CMV negative or filtered leukocyte reduced blood for that patient. The G6PD test can predispose certain populations to a hemolytic reaction to certain medications that we use, such as dapsone and sulfonamides. Those that highest risk for a G6PD deficiency include those of African, Mediterranean, Asian, and Sephardic Jewish descendants.
And Dr. Gilliam, we have a question from Jay Cat.
Yes?
Hello, Dr. Gilliam. I have a question from a couple slides ago. You mentioned you were talking about undetectable viral loads. When someone's undetectable, can they still pass the virus on?
There is never a time when you can actually say that virus cannot be transmitted. It's kind of a probability factor. The lower the viral load, the less of a chance that you're going to be infected, but the chance is never down to zero. I could go on and talk about treatment as prevention and stuff, but I don't think I can. Did that satisfy your answer or your question for now?
Thank you very much, Dr. Gilliam.
You're very welcome. Okay, some supplemental tests. I use the word supplemental because these tests are done only in specific circumstances. For herpes screening, if the patient has not had a history of chickenpox or shingles, you might want to check for a varicella zoster IgG, and then if the patient has a CD4 count of greater than 200, you might want to consider vaccination. Again, that will be covered again in the vaccination webinar. In some settings, men with low CD4 counts or not may have low testosterone. Testosterone replacement therapy is used fairly frequently to improve energy levels, increase lean muscle mass, but I want to caution you that we should only think about testosterone replacements in the event of a low or a very low normal testosterone level, say less than 350. The HLA-B5701 test is a relatively new assay to detect a genetic link to a predisposition to a very serious hypersensitivity reaction to one specific antiretroviral agent, and that drug is named abacavir, and its trade name is Zyogen. If positive, if the person is positive for this HLA-B5701 gene, there is a high risk of a bacavir hypersensitivity reaction, and that drug should not be used. This hypersensitivity reaction has always had a giant black box warning that when patients saw it, they would be afraid to take the first medication. At least now, if we choose to prescribe the drug, and it's a very good drug with a very good track record, we can explain to them, despite the fact that they read that black box warning, that we have a way now to predict very accurately whether or not they'll have a reaction. If we explain that if they're HLA-B5701 negative, there is a very low risk of that hypersensitivity reaction. Just to note that this medication, abacavir, is contained in a couple of medications that are co-formulated with other medicines, so when we begin the discussion of antiretrovirals, we'll be sure and point that out. But for now, if you think or see something about a co-formulated medication, always look for the presence of abacavir and make sure that you have an HLA-B5701 test recorded in the patient's chart. The co-receptor tropism assay, there are two co-receptors on the CD4 molecule that are required for the HIV virus to be able to successfully bind to the CD4 cell. There is a new class of drugs that can actually block HIV from binding to the CD4 by blocking a certain co-receptor on the molecular surface. This drug blocks the CCR5 receptor site. If the person has that receptor site solely, that drug is a possibility for that person to use. The assay actually tests for an additional co-receptor or a mixture of the two co-receptors, and the results tell you very clearly whether or not that patient will be a candidate for that particular drug. You would only order this test because it's quite expensive if you're considering the use of a CCR5 antagonist. And the name of that drug, the only one available at this time, is Maraviroc, and the trade name for that drug is Cellzentry. Promised slide about hepatitis serology. I know that most of you in primary care routinely look at hepatitis profiles on your patients. The one thing I'd like to caution is that you may have to design your own panel for hepatitis. Many times the hepatitis panel that's offered, already packaged by commercial laboratories, is put together to provide information about an acute hepatitis infection. They won't necessarily provide the markers that can give you information about chronic infections or immunity. If you'll notice the question marks that I have beside the hepatitis B DNA and the hepatitis C RNA, there's a possibility if a person is severely immunocompromised that they're anergic or unable to produce antibodies that show they've been infected. If there's a strong suspicion of a chronic infection with hepatitis B or C, say their transaminases are 3 or 4 or 5 times normal, their platelets and albumin are low, and your clinic is located in an area that has a large problem with IV drug use, you might want to measure a hepatitis B or C viral load test. There is a free pocket guide available that's called Clinician's Guide to HIV and Hepatitis A, B, C, and it was put out, the most recent edition is February of 2010. It's available from the Mountain Plains AETC, and we can make that available to you as a PDF, and if you like it, we can also arrange for you to get a pocket copy of that guide. STI screenings for all patients. You don't want to assume that your HIV patients are high risk or medium risk or low risk. The screenings that are recommended for STIs for HIV patients are for all your HIV patients. You'll want to test them annually or as needed for symptom complaints or exposure for syphilis. And I just wanted to make you aware of something that's new, actually just about 3 weeks old to me, is that there are some new syphilis tests available with values that are very different than what we're used to seeing. So if you start seeing things that are different from your traditional RPR and treponemal assays, check with your lab to make sure that what you think is reactive is really a reactive test and not a residual factor from an old infection that was treated. When thinking about testing for gonorrhea and chlamydia, there's a lot of cost variation with test sophistication. If you can afford it, consider your urine-based nucleic acid amplification tests for GC and chlamydia, but if not, you can go back to some of the other standard DNA probes. You'll want to consider sampling from various sites depending on the sexual practices of the individual that you're talking to. There's a probability of pharyngeal and rectal GC that may be so asymptomatic that the patient would not be coming in with complaints. Just another sidebar is that some laboratories will not run a GC sample from the rectum or pharynx because this test has not been approved and validated from the manufacturer for those applications. Many of us just label it as a sample from the urethra or cervix and go ahead and send it off. Additional tests for women with HIV include a GYN exam with a PAP test soon after diagnosis. The incidence of abnormal PAPs is much higher in patients with HIV disease. If you can get at the same time of the GYN exam, you could also get a cervical specimen for GC and chlamydia using the DNA probes. And of course, in one mechanism or another, you'll want to examine the vaginal secretions for trichomonas. And if your clinic has a protocol for treating partners, then certainly consider treating the partner of the lady with trichomonas, or at least providing good education and refer the patient for testing and treatment. I wanted to mention that there are some new CDC STD guidelines that came out in December 2010, and there are some key changes, and the biggest one is in the treatment of gonorrhea. The primary, and the changes reflect the increasing antimicrobial resistance to gonorrhea to many of the drugs that we've traditionally used. And now the first line of treatment for gonorrhea is IM Rocephin. So I'll refer you to those guidelines, and there's a nice section at the beginning that will highlight any changes that you have from your previous practice standards. Additional screenings would be a TB screening done on admission and annually, or if symptoms are occurring, and this can be done either through a tuberculin skin test or an IGRA. We have a lot of difficulty getting patients to return to the clinic to have the skin test read, so in many settings, the clinics are moving to the IGRA testing. Always with a chest X-ray if there's any pulmonary involvement, and once a year, particularly if they have a low CD4 count, you'll want to get a dilated retinal exam. CMV retinitis is almost a thing of the past, but yet for patients that are presenting late in the course of their disease, there is definitely the possibility that they could have CMV retinitis. So you would also want to continue this exam annually. This is the last slide, and it's just a tease for what's coming up next in the next webinar. We're going to talk about varying disease states and various problems that can occur with different levels of CD4 cell counts. We'll talk a little bit about that question we had earlier about when to start antiretroviral medications, but we'll specifically focus on the number 3 category for those patients whose T cells are under 200 in terms of needing prophylaxis against certain opportunistic infections. If you see this these categories from CDC or from the World Health Organization classifying patients as A, 1, B3, C2. Don't worry about it so much for now because we'll explain it at another time. And with that, I'll open the floor to questions.
All right, Pat, let's assume that we will have 3 to 5 minutes worth of questions. We are currently at 37 minutes, 36 seconds before we entertain any questions.
Okay.
So, I mean, I think that we can realize some savings. We won't have the interruptions. We won't have you asking who's talking over you, blah, blah, blah. But if there are some places where you can shave a couple of seconds and
I mean, luckily we told people to expect 45 minutes for this first webinar in the last, well, at least, yeah.
But there are some places that I can stop, I can shave. I can do that, not to worry.
Okay.
Yeah, if there's any fluff at all, I would encourage us to shave it and let the real meat of the webinar be what's delivered.
Okay.
But otherwise, Pat, it sounds great. Your delivery is easy to listen to. Your slides are all on point. I highlighted the slide where you had a correction that you wanted to make. It's on Christine's computer. I was sitting at both my desk and her desk while we were listening. It sounds great.
Thanks. What did cause all that racket and me being able to totally hear every word that I said as an echo?
I had my speakerphone on, and I wasn't muted, and I was trying to communicate with Christine while she was running back and forth.
Oh.
And I think Nico's line was open as well.
Yeah.
So we had a lot of lines open. So.
Okay.
Garrett was able to mute everybody.
Perfect.
So it sounds great.
So what time are we getting back on?
12:20.
No, I think, well, how about 12:15? 12:10?
I don't want to be that long on it. 12:15.
Jared, I'll join you at 12:15.
Getting people situated, comfortable.
Absolutely. And we're gonna run over to somewhere and find something to put on this table so that it's not quite so loud. The other thing I think we might want to do is move these tables further away so there's less surface here to bounce on.
Okay.
Or move this table up closer or something so that we've got, we're going to try to work on a couple of things. We'll make a couple of telephone calls from this room internally and see if it's real bouncy when we get additional fabric in here.
So who should help me with those couple of slides, making sure they're rearranged like we talked about at the beginning? And
I have a slide deck that I was working on making changes to.
And I highlighted and read the ones that needed to be changed.
Okay. So on our end, we'll do that on our end. I'll send you what I have just for your final review.
Or if you want to talk through it following this right now.
Yeah, we can talk through it now. I'm still on the line, although this is probably the most expensive line to be on.
Yeah.
So let me call you back.